Hello, everyone. Welcome to Zooming Through ID. I'm Dr. Gopal, an infectious disease physician practicing in South Florida, trained at Duke University, been practicing for 20 years now. I am the APD for the Infectious Disease Fellowship program. I'm a faculty for internal medicine and the antibiotic stewardship chair here and infection control chair at Broward North. Zooming through ID is an opportunity that I've created to nurture a collaborative environment among residents at Broward. And I'm very delighted we have a new member here today, our brand new infectious disease fellow joining us. Teaching is one of my passion, but teaching somebody else how to teach, that's even more delightful and it's fantastic feeling. And I love creating these mentorships. In my experience, in my many years, many of my best mentors were the people that I met during my different stages of training, and that is awesome. So Amir is going to be all of your resource moving forward, and I will let Amir. You can go ahead and introduce your full
Hi,
name,
Dr.
your
Gopal.
age, and your passion, and tell us a little bit about yourself. And yeah.
Yes, absolutely. So my name is Amir Zayzoun. I am the first fellow BGY4 Infectious Disease Fellow at Broward North and Broward Health. So I was working as a hospitalist for the last 3 years, but I always actually, even when I was resident, I had passion about infectious disease. I wanted to start infectious disease fellowship, but during just due to some personal things. So I decided to work for some time as a hospitalist and at the same time got some experience from my work. And now at the time I just started Infectious Disease Fellowship. My first rotation at Broward North with Dr. Gopal,
Okay.
and it's amazing so far. So I'm excited to work
Wonderful.
with everyone, with all the residents. And if you have any question about
Okay.
what as how it be as infectious disease fellow. So I'm here all the time.
Yes, yes, wonderful. Very, very nice to have you.
Thank you.
And Nick is here, and he was great rounding with me. And I know Nick for like many months now, right? And you're a yeah. This is time flies. So Nick, go ahead and introduce your full name and where you did your schooling and your passion, and then you can we can start. And Nick is going to talk about HIV, and the article I gave you is Dr. Gandhi's. Is that the one you're doing today? Yeah, wonderful. And he's one of the leading, voices for HIV. He's, trained at, he's at Harvard. So, Nick, I will let you talk now.
Yeah, sure. So my name's Nicholas Petit. As of this week, I'm a third-year resident internal medicine here at
Congratulations.
Broward Health North. Thank you, thank you. A little crazy week, but it's fun. Anyway, I rotated with Dr. Gopal. She offered this opportunity to present to the infectious disease and everything. We selected this article together. Of course, she taught me a lot, so I hope, I can share some information with everyone listening as well.
Okay, great. So I will let you share the screen and yeah.
Get started. Please feel free to, chime in or ask any questions in the presentation. Happy to, have a discussion as well.
Wonderful.
So this is, let me get this started. This is antiretroviral drugs for, HIV. As she said, this is by Dr. Gandhi. This is the International Antiviral Society panel. This is the exact paper if you want to look it up, all the information. This is where I got all the information.
Can you see yeah, I can see the screen. Okay, fantastic.
Yep. Sounds good. So first, the first part is when would we start antiretroviral therapy? So typically, as you can see here, unless there's an opportunistic infection, we typically want to start it as soon as possible. This could even mean same day of diagnosis if there's no suspicion for any opportunistic infection. We really, it's emphasized throughout the journal that, we want to start this antiretroviral therapy as soon as possible just to help the patients the most. As far as specifically, like, in the hospital, we'll see patients their first time getting diagnosed with HIV. Maybe they have an opportunistic infection. So let's say somebody has TB. You want to start the antiretroviral therapy within 2 weeks, especially if those patients have a CD4 count less than 50. If somebody has TB meningitis, we want to start usually within 2 to 4 weeks. Importantly, this would be after the patient is stable. More importantly than antiretroviral treatment for these patients is high-dose corticosteroids and the tuberculosis treatment. So this should be, the focus immediately, and then the following 2 to 4 weeks, we should start considering antiretroviral therapy. For crypto meningitis, it's pretty much the same recommendation, the 2 to 4 weeks post antifungal use. And then if somebody has asymptomatic crypto antigenemia, so their antigen's positive, we want to start the ART actually immediately along with the fluconazole. So these are some just examples you might see and when we would start. So I know this is a kind of a big slide. There's a lot of different medications, of course, but I tried to make it as clear as I could. So what therapies are recommended? So typically, I thought this was a really helpful quote at the top. So regimens composed of the integrase strand transfer inhibitors. So this is like bictegravir or BIC or dolutegravir or DTG. These are typically recommended for people with HIV. The reasoning is they have very high viral suppression rates. Most patients tolerate them very well. They infrequently become toxic. They don't have a lot of drug-drug interactions. There's a high barrier to resistance, and a lot of these drugs come in combination pills. So there's a low pill burden. I just gave some examples of brand names on the side here as well. Biktarvy as an example. So the tenofovir, alafenamide, TAF, or tenofovir disoproxil fumarate, TDF, or TXF, and the emtricitabine or the lamivudine or the 3-TC, XTC. These remain the recommended nucleoside or nucleotide reverse transcriptase inhibitors. They're components of the initial ART regimen. So this is like the most common, the following recommended combination drugs. And there's also like the anchor drug, which is the main, first drug. So this is what's recommended for most people with HIV. So that would be like the BIC/TAF/FTC. And this has a very high evidence rating. Or you can do like the dolutegravir plus the TXF plus the XTC. Again, also highly recommended. Those are the two common ones.
So I'll just quickly I just want to briefly say about the approved antiretrovirals. These right now we have the old ones were the NRTIs, that is the ACT and lamivudine, abacavir, FTC, tenofovir. Those are the NRTI class. The second class is the NNRTIs, and those were the efavirenz, nevirapine, that's an old drug. We have the rilpivirine and doravirine, efavirenz. Those are the NNRTIs. Then the protease inhibitors got approved. Some of them we don't even use, but those are all boosted. The ritonavir, lopinavir, atazanavir, darunavir, those were the protease inhibitors. But the main class that we are basically right now, the top of the line we are using is integrase inhibitors. That's where the raltegravir, that's the old Icentris, then the DTG, the bictegravir, that's the Biktarvy, that's the combination we use, and then the CAB, those are one of the new ones. And then came the entry inhibitors. Those are the meravoric, the fusion inhibitors. And then we have the latest one is the capsid inhibitor, that is the lenacapavir. So those are the classes, and these are the regimens that we start. That's wonderful. And going back to the previous one, the main take home in terms of when to start antiretrovirals, Earlier, there used to be like different CD4 counts, but now we don't need to look at the CD4 at all. The antiretroviral therapy is definitely indicated, like Nick was mentioning, the sooner the better. We need to start. Basically to suppress the HIV viral load, and then we have to preserve their immune function, and then this delays the clinical progression. So one other point I need to emphasize on is, you will get a scenario where a patient is coming in with acute HIV, acute HIV syndrome, and we are supposed to offer antiretroviral treatment for them that will reduce their symptoms and sign, and they reduce their transmission also. For pregnant patients, no matter what the CD4 count, we have to give them antiretrovirals because it prevents the maternal fetal transmission. And TB, of course, we obviously will start the TB treatment right away. But if the CD4 count is less than 50, we should start antiretrovirals. But if it is greater than 50, it is okay to wait a little bit, because obviously when we start the TB meds, we are introducing a lot of toxic, a lot of side effects. So we need to monitor, and also immune reconstitution syndrome can happen. So that's why if the CD4 is more than 50, we can wait. So those are some of the points. Yeah, go ahead.
So something that, we can get exposed to is what happens if somebody gets HIV after they're already taking PrEP therapy. So, PrEP meaning pre-exposure prophylaxis. So if somebody acquires HIV while receiving the PrEP therapy, they should have basically blood sampling for genotyping. So, they could have resistance to these medications, and these should be drawn prior to initiating therapy of a 3-drug regimen. So preferably the ones we talked about, the dolutegravir or the bictegravir, plus the TXF or XTC. These should be initiated if ART is to be started before genotyping results. But persons, if you required HIV after exposure to the cabotegravir for pre-exposure prophylaxis, you should then have the blood sampling for the INSTI genotyping drawn prior to the beginning therapy with an INSTI-based regimen. And if therapy is desired before genotype results are available, so if you want to start it like right away, and then there's resistance, either present or suspected, then you can use these other drugs, the ritonavir, the
Cobicistat, yeah.
boosted darunavir. Yes, sorry, the very complicated name. And the TXF XTC, these should be used.
Yes.
So I just thought this table was helpful. I'm not gonna, I don't think it'd be helpful to read it all, but just to have it. Sorry, my screen, let me move that over the way. This is other recommended initial therapies. I thought this is a helpful combination table just to take a look at if you want to later on. So a common thing would be a patient who's pregnant, who's diagnosed with HIV. So for these patients, recommended during pregnancy is the TAF-XTC plus the dolutegravir with the TDF-XTC plus dolutegravir as a suitable alternative if the tenofovir alafenamide is not available. These are some other drug options that are possible, just not, they wouldn't be the first line recommended. I put a list here as well. So then what if the patient has latent or active TB? So for these, this example, these patients, the TXF-XTC is recommended with one of the following, most commonly the dolutegravir during the tuberculosis preventative therapy. These drugs are not currently recommended, so the DTG3TC or the BICTF-FTC, because there's a drug-drug interaction with rifampin. So if the patient's getting treated for TB and they're on rifampin, this can be a problem. Basically, there's a pharmacokinetic interaction between the rifampin and the tenofovir alafenamide, and there's not a lot of clinical data about the co-administration, so it's just recommended to be avoided if possible if you need to provide the patient with the rifampin.
Yeah, and one
So,
more point
yes.
about the TB and HIV drugs. Like you said, rifampin does interact with many of the medicines. So all the PIs, I mean, we generally don't use with rifampin. If we are using efavirenz, we have to use the 600 milligram daily dose when we are, treating.
So let's say we want to switch therapies on a patient. So the patient already has HIV, they're already on a medication. Let's say they do have virologic suppression. So some reasons that we might switch would be either toxicity from one of the drugs, maybe a drug interaction like we just talked about with the rifampin. Some of these have comorbidities. Sometimes if a patient's on an older drug, they might have a high pill burden drugs, and maybe there's an issue with insurance or something with the cost. So things like if older regimens, a lot of, like I said, there's a benefit to simplifying the regimen so that the patient will be more adherent to the medications. In some patients, you may consider dual therapy instead of the triple therapy. But there's some things to avoid. So you want to avoid the NNRTI-based regimens or first-gen INSTIs if prior NRTI resistance is present. So if this is already checked, of course, you don't want to prescribe them if there's resistant. And then there's risk of treatment failure due to the lower resistance barrier. So just kind of continuing the discussion with switching therapies. So, switching therapy with blips or low level viremia or virologic failure. So I just wanted to kind of make one important distinction that I learned about. So intermittent detection of HIV at RNA levels between 20 and 200 copies per milliliter. This is just referred to a blip. It's just what we call it. It's a persistent low level of viremia at this level. It should not prompt changing treatment. So just because their RNA levels are between 20 and 200, that wouldn't necessarily mean they're having failure. We just call that a blip. Virologic failure occurs when the ART fails to achieve or maintain an RNA level below 200. So let's say it goes up above 200, then we would be thinking more about virologic failure. So evaluation of this virologic failure would mean, first of all, adherence. So is the patient taking the medications as prescribed? Are they missing doses? Or, what's kind of going on there? Is there any interaction with other drugs? Maybe the supplements the patient is taking. These are things you want to be careful about. It may not be that the drug's not working. It may just be that, they're not taking it or there's an interaction. So if the patient does have virologic failure with extensive multi-class resistance, including the INSTIs, you want to switch, of course, to medication with novel mechanisms of action. And as you can see here, there are some lists of other options, ideally in combination to allow two fully active drugs. So you want to make sure that at least two of the drugs the patients are on are going to be fully active, no resistance for there. There's also the option of injectable therapies. So, many of them are oral. There's kind of criteria for these though. So the criteria one is you are unable to take oral therapies. You have to have high risk of HIV disease progression. And the virus, of course, as we talked extensively, it has to be susceptible to these medications. So the most common ones I saw were the long-acting cabotegravir plus the long-acting rilpivirine injectables. So I thought this table was helpful. So this is, this is some laboratory monitoring that should be done with a patient who's established with HIV. So basically, the HIV RNA levels, the CD4 count, things like this. So at diagnosis, we want to do all these things. The genotyping, as you can see, the HIV reverse transcriptase protease genotype. Whereas if the patient is on ART, RNA levels would be 4 to 6 weeks after initiation, then every 3 months until suppressed, then every 6 months once there is suppression. The CD4 count would be every 6 months until greater than 250. Then you would do every 1 year. And then, there's a few other things here as well. You always want to do things like screening, monitoring for metabolic disease. That's a very, very common side effect as
And
well,
we
which
are
we're about to get into here.
Yeah. And if we are placing the patient on abacavir, which we don't use these days unless in certain scenario, for abacavir, we test them and see whether they have the HLA B5701, that we do the testing prior to initiation. Yeah. Okay.
So commonly with these medications, we get weight gain or cardiometabolic comorbidities. So you have to monitor the patient's BMI, their weight, blood pressure. Blood pressure should be done at each visit. However, it's not a reason to stop just because the patient has weight gain or hypertension or insulin resistance. It's just recommended that you make sure and get those things treated accordingly. It wouldn't be a reason to stop. It'd be more important to continue the antiretroviral treatment. You want to document this typically every 6 months at least. People who are at high risk in receiving abacavir should switch to a non-abacavir containing regimen if there's another regimen available. And then we always want to counsel patients about these things, let them know the side effects of the medications, the cardiometabolic complications, importance of diet and exercise, everything that honestly we should all be doing as physicians anyway. Just something we want to be aware of. So of course, when we talk about HIV medications, go back. There's the association with substance use disorders. So when the patient comes in, either a new diagnosis of HIV or maybe we're just screening for high risk, we want to make sure we talk to them, provide that screening, diagnosis, and treatment for the substance use disorder. So either medications or options that can help them, like social work type of stuff that we can help them with. We also want to do rapid HIV testing and PrEP as appropriate when indicated. That's appropriate for patients who have substance use disorders. We want to include things like harm reduction services, so things like including the naloxone if the patient's using, opioid medications, safe injection practice education, things like fentanyl, drug testing strips, and all this stuff. Even though this isn't specifically related to HIV, it's still something we want to, make sure we're addressing with patients. And then there's the oral TDF-FTC for injection drug use, or the oral TDF-FTC or TAF-FTC, or injectable PrEP. And this is helpful to reduce, sexual risk of HIV acquisition. So how would we prevent the spread of HIV? So first off, we should adopt a serostatus neutral approach. We really want to try to reduce the stigma of HIV, want to make sure we treat them appropriately, quickly, and help those who need PrEP to get those PrEP, as soon as possible and as appropriately. Basically, PrEP, it's pretty liberal. So those sexually active, those requesting it, those using non-prescription drugs or substances, even without specific criteria or screening tools, it's actually now recommended that we offer PrEP to those patients, especially those who use IV drug use, those with sexual partners, or with HIV. We want to be very open to offering PrEP to those patients. For patients with monogamous sexual partners of HIV, if they're known to be receiving antiretroviral therapy and have viral loads below 200 copies per milliliter, it's actually reasonable and appropriate to defer the PrEP. So if they're monogamous and they have below that 200, we can defer it. However, if the patient requests it, it's also still reasonable to provide it. So even though we don't necessarily have to, because the transition rate is very close to zero, essentially 0%. We can still offer it to the patient to help them if they're in this situation. And then of course, condoms are recommended for all penetrative sexual acts. So for the rapid PrEP start, as we were talking about, if there's HIV test results within the past 7 days are negative, then we would initiate PrEP. So we want to, of course, test these patients for HIV before starting. If there's no, so for instance, if there's no HIV test result, we need to test and then initiate PrEP once the results are negative. If a patient, though, had substantial HIV exposure within 72 hours, we want to initiate the 3-drug PrEP regimen recommended right away, as opposed to the 2-drug regimen, which it would be for PrEP. So this would be PEP, meaning, sorry, I should have clarified, that would be post-exposure prophylaxis. Transition to PrEP after post-exposure prophylaxis. Completion if HIV test results are negative. I think that's pretty much it for this. So this is just a nice table I found in the article. This is the recommendations for the approved HIV prevention by type of exposure. So, you can see the types of exposure here and then what's actually recommended. It kind of just depends on what, what risk the patient has for HIV exposure, what medications we would recommend. One big takeaway is typically for PrEP, it would be a 2-drug regimen only, as you can see here. So I did add some questions just to kind of put everything together. These are from MixApp, more internal medicine boards level, but we'll just go over it anyway. So I'd be appreciate if Dr. Zayzoun, if you want to answer the question when we're done. So question 1, we have a 35-year-old man. He undergoes follow-up evaluation for a positive HIV screening test obtained 3 days ago. He's ready to start treatment. HIV testing 1 year ago is negative. He takes no medications. The physical exam is normal. 4th generation HIV 1 and 2 antigen antibody combination immunoassay is positive, with the differentiation assay positive for HIV-1 antibody, and HIV-1 quantitative RNA is 25,640, and CD4 count is 540. So for this patient, which of the following is the most appropriate management?
So because we said we have to start ART as soon as possible, he's not taking any medications, so I would choose ART now.
Perfect. Yeah. So that's exactly what we talked about in the first slide. So this would be starting now. So we already have the first test as well as the confirmatory test. And then this patient, we're not concerned about an opportunistic infection. So we want to start the antiretroviral therapy right away. Perfect. So here's another question. 42-year-old man, HIV infection. He seeks advice regarding HIV transmission risk. He's in a committed monogamous relationship. His husband is HIV negative, confirmed through the testing. His HIV infection has been well controlled for 10 years. His only medication is a fixed co-formulated regimen of the tenofovir, alafenamide, the triple therapy regimen here. Laboratory studies one week ago showed an undetectable HIV quantitative RNA, which remains the same from 6 months ago and 1 year ago. And his last CD4 count was 650. So which of the following is the most appropriate management to prevent HIV transmission? So basically, this patient has been undetectable for 6 months and 1 year ago, and he has a CD4 count of 650. What would be recommended?
So consistent condom use with each episode of sex, I mean, that's recommended for sure. Really HIV pre-exposure prophylaxis for the partner. Med HIV pre-exposure prophylaxis for the partner. No additional preventive strategy necessary. I would go with the consistent condom use each episode of sex.
No,
Okay. But also, yeah, I would go with A.
the
What do you
main
think,
thing is
doctor?
U equals U. This undetectable is,
Mhm.
oh, I'm running out of time. Yeah. So yeah, Nick, go ahead.
Yes. So I actually got this question wrong when I did it.
It's U equals U. That's the thing, right? Yeah. So no, undetectable is not, we are not able to transmit. So there is no need for any additional strategy. That is the answer because there has been more and more data about U equals U. So the key is this patient is saying he's on a monogamous relationship and the whole thing changes if there is any issue in that part. So the stem prepares you well for that question. So all of those question answers are right in different ways if you think about it, but the stem says that these people they've been in a monogamous relationship, so there is no extramarital relationship there. and then undetectable. So U equals U, undetectable is equal to untransmittable. So that is the key in this one. Yeah.
Even if the partner doesn't have HIV, so still,
No, but
even if
even
he,
if the HIV is there,
mm,
the viral load is undetectable. And there is
mm,
the monogamous relationship. So there has been many
okay.
data these days about the U equals U. So that is the key that there are some articles, and I will share that with you. Yeah. So there has been more and more data about that. But if there is any issue in the relationship, then definitely there are people who come into the office and they will ask for the pre-exposure prophylaxis, even though they've been with a partnership. So at that time, they are giving us a clue that there is some interest in some other type of relationship they may engage. So then we give them pre-exposure prophylaxis in those scenarios. But technically, if the partner is undetectable and if the person is only having relationship with the partner who has undetectable viral load, so it's not transmissible. So that is the key take home in that one.
Yeah, I mean, I think this is helpful, even for infectious disease doctors, but even, primary care doctors, hospitalists. I feel like we can all be
The
asked this
stem, we
question.
have to
HIV
carefully
is
read the
undetectable for
stem of
6
the
months, 1 year.
question. Yeah, this question can be asked in different ways. We can make the answer right for, it all depends on the stem and yeah, very nice. Yeah, that's good.
All right, we have another question. So this is a 32-year-old male. He's been hospitalized for 2-week history of gradually worsening headache and fever, diagnosed with the HIV infection 1 month ago, but has yet to initiate antiretroviral therapy. Medical history is otherwise non-contributory. He takes no medications. Physical exam, the patient is lethargic but responds appropriately to questions. His temperature is 38.1 degrees Celsius. Other vitals are normal. There are white plaques present on the palate and the buccal mucosa. Laboratory studies show a positive serum cryptococcal antigen test 1 to 256, an HIV viral load 95,640, and CD4 count of 42. A non-contrast CT scan of the head is negative, so the IV liposomal amphotericin B and the oral fluticasone they're initiated.
Mhm.
So which of the following is the most appropriate next step in the management of the patient?
So let's see. Fluconazole. I don't believe he's already on amphotericin and oxytocin. I will not go with this answer. Perform LP. Mm, I mean, the patient's, I don't think we need to perform LBF. We have him positive serum cryptococcal antigen already. And so his CD4 count is less than 5042. He said we are going to start ART for CD4 count less than 50. But the question, which one, the abacavir, lamivudine, or the tenofovir? I will go with the. I'm not sure, to be honest, but I will go with D, tenofovir, Herceptine, and dolutegravir. But either C or D. I'm not sure which one.
Okay.
So this is a patient they are giving in the stem, yeah. You want to talk, Nick,
All
or?
right, sure. Yeah. So this is the patient, right? They have the cryptococcal meningitis. So these patients can have very high intracranial pressure. So I know it sounded like you were saying, maybe the lumbar puncture would be for diagnostic reasons, but it's actually therapeutic for decreasing the intracranial pressure. If we don't decrease it, it could lead to blindness, deafness, and coma. The other thing in the beginning of the presentation, we discussed briefly about when to start ART. For this patient, he has acute infection of cryptococcus, so we wouldn't actually want to start it right away. He has an opportunistic infection. We would wait about 2 weeks, maybe 4 weeks, depending on the patient's clinical status and how well they do and everything.
Yeah, sometimes even 8 weeks, because cryptomeningitis is one of the exceptions where we have to be very careful about the, complications. So that is one case where we definitely will be waiting for the antiretrovirals. And this patient with very lethargic and the CNS pressure is high with the cryptomeningitis, and we do the therapeutic tap. Yeah.
Okay. Alrighty. It's another question. We have a 31-year-old male. He seeks advice regarding PrEP for HIV infection. He was treated for rectal gonorrhea 3 weeks ago and syphilis 1 year ago. He's not been sexually active since his gonorrhea diagnosis. He has had receptive and insertive anal sex with multiple partners over the past year. Condom use has been inconsistent. He takes no medications. These are his lab values. Repeat testing for the gonorrhea, chlamydia, and syphilis is negative. He is counseled regarding consistent condom use and the need for periodic screening for sexually transmitted infections. So daily treatment with which of the following is most appropriate additional management?
So he's very high risk. He's not been sexually active since his gonorrhea diagnosis. He has had a partner. And his condom use is inconsistent. Really. Um, so I will give him the pre-exposure prophylaxis. Go with B, tenofovir.
Yeah, that's good. So, yeah, exactly. He's high risk. He has multiple sexually transmitted infection history, high risk for HIV. He would be an appropriate patient to start PrEP. The easy way to remember, especially, at the resident level, would be the 2-drug regimen is typical for the PrEP. The 3-drug regimen is typical for treatment. Anything else you want to add, Dr. Gopal, or?
No, that is great. I mean, the main
That's pretty
thing,
self-explanatory.
yeah, the PrEP, and then we never do monotherapy for anything for the HIV. So always, ideally, 3-drug is mainly preferred for treatment. And then PrEP, we have so much options, and PrEP itself is like a full lecture, 1 hour lecture. We have so many options now, yeah, for the PrEP.
I have a question. So always we admit patients to the hospital. They were at one point with the AR, they started ART at one point, and then they couldn't get a refill, or they missed follow-up with their HIV doctor.
So what I would
tell
recommend,
you, oh, I didn't take my medication for
yeah,
2,
it
3
is.
months.
Yeah, so it's not good to continue with the same medicine because they should demonstrate compliance in the office. Otherwise, we are brewing resistance if they are just restarting them. So it is not at all good if they don't take the medicine, we are adding more resistant pathogens. So that is not, I mean, they should demonstrate compliance. I try to hook them up with the free clinic if they don't have, the health departments, they have different clinics they can go, and those are some of the avenues that we have. I think we are running out of time. We have less than a minute. So this was a great presentation, Nick, and thank you, Amir and Nick, for doing this, and